Assalamu alaikum students. Our today's topic is gross anatomy of palatine tonsils. So let's start with the topic. Before going to start the topic of palatine tonsils, first you should know what are tonsils. These are basically the aggregations or masses of lymphoid tissue present in relation to the naso-oropharyngeal isthmus, and they act as first line of defense against microbes. There are four aggregations, which are pharyngeal tonsils, tubal tonsils, palatine tonsils and lingual tonsils. Most important of these are palatine tonsils. So today we will discuss only the palatine tonsil in detail. First of all, the location of the palatine tonsil. These are present in the oropharynx, occupies the tonsillar sinus or tonsillar fossa. Tonsillar sinus or fossa is present between the palatoglossal and palatopharyngeal arches. Palatoglossal and palatopharyngeal arches, we already discussed that these are mucosal folds extending on each side from the uvula downwards and laterally. Here in this diagram you can see this anterior fold is called the palatoglossal arch and this posterior fold is called the palatopharyngeal arch, and between these two folds there is the tonsillar sinus or tonsillar fossa which lodges the palatine tonsil. Now the tonsil has two surfaces, medial and lateral, two borders, anterior and posterior, and two poles, upper and lower pole. Now here is the medial view of sagittal section, where you can see above this is the nasal cavity and then the hard palate and soft palate, and below there is the oral cavity. Here is the palatoglossal arch and here is the palatopharyngeal arch. Between these two arches there is tonsillar fossa or tonsillar sinus which lodges the palatine tonsil. This one is the palatine tonsil. Now the palatine tonsil has anterior border and posterior border. Its anterior border is related to the palatoglossal arch along with its muscle, and its posterior border is related to the palatopharyngeal arch along with its muscle. It has upper pole which is related to the soft palate and lower pole which is related to the tongue. And here you can see the medial surface of the palatine tonsil which faces to the oral cavity. Lateral surface you can't see in this section. The medial surface, which is facing the oral cavity, is covered by stratified squamous epithelium continuous with that of mouth. It has 12 to 15 crypts. Now here you can see the medial surface of the palatine tonsils showing crypts, and largest crypt is called the intratonsillar cleft. This one is the intratonsillar cleft. A peritonsillar abscess or quinsy often begins in this cleft. And what is peritonsillar abscess? We will later discuss in this lecture. Now the lateral surface is covered by a sheet of fascia which forms the hemicapsule of the tonsil. Now in this coronal section you can see the lateral surface of the palatine tonsil which is covered by a hemicapsule. And why it is so called? Because it only covers the lateral surface of the palatine tonsil. It is basically the extension of the pharyngobasilar fascia, and it is attached loosely posteriorly, where it is loosely attached to the wall of the pharynx, and anteroinferiorly it is adherently attached to the side of the tongue by the suspensory ligament of tonsil just in front of the insertion of the palatoglossus muscle, and this firm attachment keeps the tonsil in place during swallowing. The tonsillar artery enters the tonsil by piercing the superior constrictor just behind the firm attachment of capsule. Now here you can see this one is the tonsillar artery or tonsillar branch of facial artery, and this is the superior constrictor muscle, and tonsillar artery pierces the superior constrictor muscle to enter in the palatine tonsil. The palatine or paratonsillar vein descends from the palate in the loose areolar tissue on the lateral surface of the capsule and crosses the tonsil before piercing the wall of the pharynx. Here you can see the paratonsillar vein or palatine vein descends from the palate in the loose areolar tissue lateral to the capsule of the palatine tonsil, and then it pierces the wall of the pharynx. Here you can see that palatine vein or paratonsillar vein is runs very close to the palatine tonsil, and this relation is very important because the vein may be injured during removal of tonsil or tonsillectomy. Tonsillar bed. Structures related to the lateral surface of the palatine tonsil forming the tonsillar bed, and it is formed from within outwards by these structures. Now look at this diagram. Here you can see the lateral surface of the palatine tonsil, which is covered by the hemicapsule of the tonsil, and next to the capsule is the loose areolar tissue, and this space is called the peritonsillar space in which the paratonsillar vein runs, and this one is the first structure which is very close to the lateral surface of the palatine tonsil. Then is the pharyngobasilar fascia. This one is the pharyngobasilar fascia. Next to it there is the superior constrictor muscle, and then the buccopharyngeal fascia. In the lower part you can see the styloglossus muscle, and then here is the glossopharyngeal nerve. Then the facial artery along with its tonsillar and ascending palatine branch, and here is the carotid sheath. Internal carotid artery is 2.5 cm posterolateral to the tonsil. Now these all structures forming the tonsillar bed, and this is a very important question from your written and viva point of view. Arterial supply of tonsil is very rich. Main source is tonsillar branch of facial artery. Here you can see tonsillar branch of facial artery. Additional sources are ascending palatine branch of facial artery, dorsal lingual branch of the lingual artery, ascending pharyngeal artery, which is the branch of external carotid artery. This one is the external carotid artery, and here is the ascending pharyngeal artery. It also gives branches to the palatine tonsil, and the greater palatine branch of maxillary artery. Venous drainage. The venous drainage is via the peritonsillar vein, drains into the facial vein and numerous small veins which drain into the pharyngeal plexus of veins. Lymphatics pass to the jugulo-digastric nodes, and nerve supply from the tonsillar branches of glossopharyngeal nerve and lesser palatine nerve. Voldier's ring. As I have already told you in the beginning of this lecture that in relation to the naso-oropharyngeal isthmus, there are several aggregations of lymphoid tissue that constitute Voldier's lymphatic ring. These aggregations are laterally the right and left palatine tonsils, posteriorly and above nasopharyngeal tonsils, laterally and above tubal tonsils, and inferiorly there is lingual tonsil. Now here you can see that Posteriorly and above there is a nasopharyngeal tonsil which is present in the roof of the nasopharynx. Also the tubal tonsils present in the roof of the nasopharynx, and the palatine tonsils we know that present in the oropharynx, and the lingual tonsil is also present in the oropharynx at the posterior 1/3 of the tongue. Now the clinical correlate. Tonsillitis refers to the inflammation of palatine tonsils. It is usually caused by viral infection, with bacterial causes accounting for approximately 1/3 of cases. Symptoms include difficult or painful swallowing, often with fever. On examination, tonsils appear erythematous and swollen with evidence of purulent exudate and lymphadenopathy. Now here you can see the red swollen tonsils with evidence of purulent exudate. Tonsillitis may cause referred pain in the ear as glossopharyngeal nerve supplies both these areas. A very important clinical correlate is a peritonsillar abscess, which is also called quinsy. It is a condition in which pus accumulate in peritonsillar space. Peritonsillar abscess is most common in children, adolescents, and young adults. It is one of the complications of tonsillitis. If tonsillitis left untreated, then infection spreads to the surrounding area and abscess can form. Other causes include mononucleosis as well as tooth and gum infections. Now here you can see that pus is spread in the surrounding area of the tonsil. Symptoms include fever, difficulty opening mouth fully and in swallowing, swelling of face or neck, muffled voice. It can be a life-threatening condition if left untreated. Results in more serious symptoms include infected lung, obstructed airway, spreading of infection into throat, mouth, neck and chest, and rupture of abscess. There are two techniques adopted for drainage of abscess: needle aspiration under local anesthesia and incision and drainage. Tonsillectomy or removal of tonsils is performed by guillotine or sneer operation. Each procedure involves a removal of tonsil and surrounding connective tissue. Because of rich blood supply of the tonsil, bleeding commonly arises from the large external palatine vein, which is closely related to the lateral surface of the palatine tonsil, or less commonly from the tonsillar artery or other arterial twigs. The glossopharyngeal nerve accompanies the tonsillar artery on the lateral wall of the pharynx. Because this wall is thin and this nerve is vulnerable to injury, and internal carotid artery is especially vulnerable when it is tortuous and lies directly lateral to the tonsil. Hemorrhage after tonsillectomy is checked by removal of clot from a raw tonsillar bed.